Thank you for having me. I'll just try to figure out how to use this very quickly here. There we go. Okay, so first of all, I don't have any disclosures. Nobody's paying me to talk about this. I wish they were. That's my waiting room, and I used to make a joke a couple years ago that that's what it always looks like. But actually, we've gotten kind of busy over the last couple years. I went to medical school, then residency in anesthesia, then I did a fellowship in acute pain and regional anesthesia, and then I ran an inpatient pain service that I developed at the local VA, and then I opened a clinic dedicated to perioperative outpatient pain management, which is pretty unique. And now we have a comprehensive pain management clinic, and my partner, Dr. Julian, will be talking to you. She's the chronic pain side of the clinic. Basically, what I started doing a couple of years ago was an outpatient nerve catheter program where patients would come to me in my office after surgery, and I'd place nerve catheters for postoperative pain, mostly for orthopedic surgery. And so we would have a program where we'd call the patient every day, and we do that extensively still. We also treat a range of other neuropathic pain conditions, ranging from peripheral neuropathies to spine pain, using a lot of different modalities, including cryoablation and such. There have been a lot of advances in regional anesthesia, which is what I'm going to principally be talking to you about. And that's a burgeoning field that continues to develop new techniques. And it's been accredited by the ACGME as its own independent fellowship recently. The important point that I want to make is it's imperative that people know what they're doing when they do regional anesthesia. I felt that my experience in my fellowship and then subsequently teaching residents for a couple years and working on these blocks in an outpatient setting and seeing the consequences of those blocks, which is something a lot of anesthesiologists don't see, is critical to being able to do these procedures well. The specific blocks that I want to talk about relate to spine surgery, and there have been case reports and case series in the past year or so that demonstrate that there are newer techniques that allow you to treat spine pain after spine surgery by utilizing fascial planes and entering into fascial planes with local anesthetic. These techniques include the QUADRATUS lumborum block and the ERECTOR SPINAE block. The QUADRATUS lumborum block can be done in one of three different ways. The block targets the various layers of the thoracolumbar fascia, and specifically the middle layer of the thoracolumbar fascia seems to be the one that allows spread of local anesthetic to the proper location. Similarly, the ERECTOR SPINAE block also seems to allow for spread of local anesthetic to the dorsal root ganglia, which is what we're after when we do these blocks for spine pain. So if you look on the right side of the screen, you can use ultrasound to guide local anesthetic into the fascial plane just underneath the ERECTOR SPINAE at the transverse process. Generally, this is done for hip surgery around T12, and it can be done for back surgery around T12 as well, because the ERECTOR SPINAE is quite a long muscle. The local anesthetic, if you use it at a high enough volume, will spread along that muscular plane, both superiorly and inferiorly, quite a ways. And so there are case reports demonstrating its efficacy. The QUADRATUS lumborum block targets that middle thoracolumbar fascia, as I mentioned before, which is the blue dot that you see on the left side of the screen. That block can also be done targeting the purple dot or the green dot, but the blue dot is the one that case reports often demonstrate results in reduced pain after spine surgery. These plane blocks have been demonstrated to reduce pain by targeting the dorsal root ganglia. Specifically, if we look at dye studies, on the left is the dye study of the QL block, on the right is the ES block, QUADRATUS lumborum and ERECTOR SPINAE. In both cases, the dye spreads to those dorsal root ganglia, and you have to take my word for it because I don't have time to point out all the various structures, but you'll notice that, for example, on the far right image, you see the origin of the dorsal ramus is pointed out, and there's blue dye surrounding both sides of that origin. So an early evidence for spine surgery has elucidated itself from about 2017 to the present, and these case reports and case series are demonstrated on various surgeries ranging from something minimally invasive, such as microdiscectomy, up to fusions. And in all cases, they've noted that the patients do demonstrate pain scores in the 2 to 4 range, but then by 8 hours, it tends to rise up to 6 to 8, so we'll discuss that. So the goal would be to do these blocks potentially prior to surgery. They have to be done bilaterally. They require expertise, and so if a person is fairly new to these blocks, it can potentially cause problems for you guys, such as delaying cases. And because they're done in an inpatient setting, you'll have to deal with any complications. Luckily, both blocks are fairly superficial and fairly safe. For example, compared to a paravertebral block, where you could puncture the lung, or you could enter into the epidural space quite easily. These blocks are done in muscular planes, a fair distance from any of those vital structures, and therefore they're a lot safer than previous techniques that were more centrally located. And then, as I mentioned, the duration can be pretty short. They tend to range from 6 to 8 hours. I talked with one of the developers of this block at the last pain conference that I went to, and he said that because the duration of ERECTOR SPINAE blocks are so short, they advocate catheter use. The alternative, of course, to catheter use is a long-acting local anesthetic. The best one in my experience is EXPAREL. EXPAREL doesn't work very well in prolonging wound infiltration, but it can prolong actual nerve blocks in a fairly consistent fashion, up to maybe 40, 48 hours. Not 72 hours, as is advertised by the company. But and the reason to consider these is because it can minimize opiates, it can reduce your hospital length of stay, make your PACU stay shorter. Complications are extremely rare. Motor block is very rare. Motor block can happen with a quadratus lumborum block because you are actually in the plane between the quadratus lumborum and the psoas muscle, and the psoas muscle contains the lumbar plexus. EXPAREL, there's good and bad about using it. One good thing recently is that it now has a C code associated with it, so at outpatient surgical centers, ASC specifically, you potentially could get reimbursed, and it's a very expensive product otherwise, about $250 a vial, and sometimes if you're going to do a bilateral block, you might need a couple of vials. It cannot be reimbursed at HOPS or in hospitals, just at ASCs, and it cannot be reimbursed in my office, so unfortunately I can't do them. I can't use this medication at my office because I can't afford to spend the $250 per vial. The use of EXPAREL does come with its difficulties. If you put it in the wrong spot, you have basically a local anesthetic infusion that's useless for the next 48 hours. And you can't titrate it, but that's less of an issue in these motor-sparing blocks than it would be in other orthopedic surgeries. Now, the other thing I do at my clinic that I've done for a couple years is ketamine. I don't do it. I provide it to my patients in the form of infusions, and I use it for depression. Recently, FDA has approved S-ketamine, which is the S enantiomer of ketamine for depression, and I also use it in select cases for chronic pain. I always do a 2-day trial for the infusions. However, you can also use ketamine in an outpatient setting. You can use it as a lozenge or as a sublingual formulation or as an intranasal spray. It has to be formulated at a compounding pharmacy, and it costs about $60 to $110 for a month's supply. So not outrageous. The newer formulation, S-ketamine, is much, much more expensive. But this, of course, ketamine comes with its own stigma, as you can see in the picture. It's considered a party drug, for example. The question I got asked during a deposition that I was giving, not for a case of mine, but as an expert, was, "Doctor, isn't this a horse tranquilizer?" And it is used in both veterinary and medicine and human medicine for many years, but it sort of has an unfair stigma as being something that causes catastrophic hallucinatory events that can be very devastating. And in fact, that can be true at anesthetic doses, but at subanesthetic doses, that's extremely uncommon. And it can be very helpful for refractory neuropathic pain in opiate-tolerant patients, which is one of the indications, for example, where I might use it if somebody is on Suboxone and needs help with postoperative pain in the outpatient setting. It tends not to be covered by insurance, as I mentioned, but it's only about $100 on average, depending on formulation, for patients in outpatient setting.